Alrighty, week 6, Pharm, Endocrine, and Diabeetus. Thyroid hormones. So the effects of thyroid hormones is to control our metabolism. They have some impact on cardiac function, growth, and development, um, especially important towards maturation in infancy and childhood. And they come from, or the thyroid produces two active hormones, with iodine being important for both of them. And this is one of the reasons why our table salt generally has iodine in it. It is either iodized or non-iodized, and they recommend having iodized salt because it's an easy way to ensure that you have plenty of iodine in your diet. So we have triiodothyronine, T3, or thyroxine, T4, both. Okay, let's move that thing. Um, both are important. Blah, blah, blah. I couldn't tell you the difference in their function. Um, and so when we have sufficient levels of iodine in the body, um, T3, T4 are properly made. They send a nice little feedback loop to the anterior pituitary, um, modifying how much TSH sends down to activate the thyroid, and we're all honky-dory. When we do not have enough iodine, the hypothalamus continues to send its normal thyroid-releasing hormone signal down to the anterior pituitary, and that tells um, the thyroid gland to release T3 and T4, but there isn't that much going on, and so there continues to be a low negative feedback loop to the anterior pituitary, which makes us that we then have excessive levels of TSH being released. And therefore we've got the thyroid gland becoming hyperactive, productive, which becomes then enlarged to make up for this effect. Um, and we have this vicious cycle until we fix it. And that's why we end up getting this goiter, is because this thyroid gland, becomes swollen and too large. When we have hyperthyroidism, some of the treatment options, the number one treatment option is to destroy the thyroid gland using radioactive iodine. It's a relatively simple, easy, I think mostly side effect free procedure. I think they actually just drink iodine or radioactive iodine. I can't remember. Um, but there are other options as well, such as surgically removing the thyroid tissue. And there are some medications as well that you can take to actually suppress the thyroid releasing hormones or thyroid hormone synthesis. Um, Whatever the cause, when we treat hyperthyroidism, it is almost always going to end up leading to hypothyroidism, which itself has its own form of treatment. With hypothyroidism, we will want to give patients levothyroxine or Synthroid, which is a synthetic form of thyroxine or T4. We will not be giving T3 because some of T4 actually will then convert to T3, and there's not really any major benefit to giving both when it converts like that. It's got a 7-day half-life. It has a narrow therapeutic range, which means that we are going to be having the patient come in on a regular basis, especially as they are first initiated on the medication to check for serum levels of Synthroid. When we have Synthroid given, if there is an overdose, I put that on there twice. No, listen to my words. Oh, good grief. There we go. When we have an overdose, then we are at high risk of thyrotoxicosis, which we covered before in PATH at some point, which is going to be presented as having severe tachycardia, angina, tremors, the typical signs and symptoms of a super hyper metabolic state, which I also believe includes a hyperthermic state. But when we do not have an overdose, Synthroid rarely causes any side effects. It does have some interactions in that it can intensify the effects of warfarin, so we may need to lower the warfarin dose to adjust for that. And if they do have chronic overdosing, then this can lead eventually to bone loss. I couldn't actually find out why that was. Other drug interactions that we can have with levothyroxine. If we have antacids, peptic ulcer drugs, calcium, iron, then the patient is going to be at risk of decreased absorption of levothyroxine. If we have an increase in hepatic metabolism, if we take some depression and seizure drugs, then there may be an increase of hepatic metabolism of levothyroxine. The way these are set up, it makes it look like levothyroxine may decrease the absorption of these drugs or increase the hepatic metabolism of these drugs. It's actually the other way around. So these drugs will cause a decrease of absorption of levothyroxine. These drugs will increase the hepatic metabolism of thyroxine. Make sure, though, then, that we educate patients on the need to separate the administration of these drugs and levothyroxine by 4 hours. And that if they are taking certain depression and seizure drugs, which will be listed as specific medications on our resources, then we may need to advocate for increasing levothyroxine doses. So some of the nursing implications for hypothyroidism, they are going to have to be on medication for their entire lives. There's no way around that. If the thyroid can't make thyroxine, then they have to be on it supplementally. The goal is to have resolution of signs and symptoms, which generally are not difficult to do with just taking the right dose of Synthroid, and we'll confirm that by having normal labs. We need to make sure that they are always aware that if they have any reason for discontinuing the medication, that they consult their PCP first. There may be an issue, say, with affording the medication, not having access for some other reason. Whatever the reason may be, they need to talk to their PCP before discontinuing the drug, and we need to educate them on that. We want to educate them on taking the Synthroid on an empty stomach because of the fact that there may be issues with absorption, such as with calcium in particular. Will decrease the absorption of levothyroxine. So take it 4 hours before or after calcium, but otherwise just 30 to 60 minutes before breakfast. We also want to educate them on the signs and symptoms of hyper and hypothyroid activity, the signs and symptoms of myxedema, which is where we have not enough. That's the opposite end of thyrotoxicosis. Thyrotoxicosis is going to be that extreme hyperthyroid state, whereas myxedema is going to be that extreme hypothyroid state. And in the case of myxedema, we need them to go to the emergency room or call 911 because the treatment of this is to give IV levothyroxine, otherwise they may die. All right, so the adrenal cortex hormones. So the adrenal cortex is actually the outside portion. The medulla is the inside. The medulla gives off epi and norepi. The adrenal cortex gives off glucocorticoids, primarily cortisol, mineralocorticoids, which is primarily aldosterone, and then androgens, which is interesting. It's, according to the book, androstenedione. I'm sure there's a better way to say that. Now I gotta look it up. All right, so it's called, where'd it go? There it is. Pronounced androstenedione. Androstenedione. So this is something that is actually produced by, I believe, both men and women. But in men, it is really kind of overpowered by the testosterone. But in women, it serves good functional purposes for sexual characteristic development. But when it comes in excess, that's where we have the development of virilization, excessive virilization, especially in women. Okay, so all those are terms for the same stuff. We all kind of knew about the, the pathway for sending stuff to do stuff. All right, so adrenal hormone excess. This is known as Cushing's disease or Cushing's syndrome, which is different than Cushing's triad, in case anyone missed the that path video. Um, and typically, Cushing's disease comes as a secondary issue from pituitary adenomas. So we have those adenomas, those kinds of tumors, glandular tumors that develop on the, I believe it's the anterior pituitary, and they cause hypersecretion of, I believe it's ACTH, adrenocorticotropic hormone, um, or is it cortico? I think it says up here. Come on, play with me. No, never mind. Corticotropin releasing hormone. This is a really funky thing. Um, okay, so we're going to go with probably a CRH. Regardless, the point is the pituitary will release a lot of whatever hormone that it sends to tell the adrenal cortex release all your hormones. And so we go and have to surgically remove them. And with that, we may need to provide glucocorticoids for a little while afterwards. The primary medication that we're going to use for that is going to be hydrocortisone, which most people know of that as the topical that you put on your skin, but it also comes as a PO form. This has both glucocorticoid and mineralocorticoid properties, so we're getting both our cortisol and our aldosterone properties, though it is bioidentical in structure to cortisol. For treating adrenal hormone insufficiency, we want to try to mimic the normal patterns of the steroid secretion, of cortisol secretion. So we naturally have a much higher dose in our bodies physiologically in the morning compared to the evening. I think that's actually, I've heard this before, that's one of the reasons why we are able to better wake up in the morning. If we actually, in this, I believe I'm not 100% sure of this, but I feel I read it somewhere reliable back in the day. If someone does not have enough cortisol in their body, there's a risk that they will not necessarily be able to wake up in the morning due to the impact that cortisol has on metabolism and the wake-sleep cycle. So we're going to be giving 2/3 of the dose in the morning and then 1/3 at night. Um, I need to figure out what that's saying. I think what's being said here is that when we are treating for just hormone replacement with adrenal hormone insufficiency, these doses are going to be less than if we're trying to go for a anti-inflammatory effect like with prednisone. So this is also known as the physiologic dose rather than the pharmacologic dose. That's what I think is going on there. When we have times of significant stress, trauma or infection, surgery, any of that kind of stuff, we're going to want to increase the dose significantly up to potentially 3 times the usual dose for 3 days because when we are in that, when we experience that kind of stress with normal functioning adrenal glands, the cortisol levels in our blood naturally rise because of the stress associated with those experiences. So we want to try to mimic that with the doses. So many case studies. Diabetes. I think I didn't skip anything, right? No, good. Diabetes. Diabetes. So this is an issue of carbohydrate metabolism. We can have either resistance to the action of insulin itself and or have a deficiency of insulin. This is normally type 1, this is normally type 2, though there can be intermingling of both. This is primarily what is driving type 1 because there's problems specifically with the beta cells, the islets of Langerhans, I think it was, in the pancreas that are not able to produce enough insulin or any. Without insulin, we have sustained hyperglycemia, the extra levels of sugar in the blood. The body's going to try to get rid of them with urine, so we're going to have polyuria. That polyuria is going to lead to polydipsia, and the body's saying, hey, we have no sugar, thinking that it has no sugar since insulin isn't working, or the cells are not receptive to insulin, is going to tell us, hey, we're hungry, so there's going to be polyphagia, and then there could be also the breakdown of lipids being used as energy, leading to ketones as like an end product being excreted in the urine. In pregnancy, the placenta, the hormones are able to antagonize the actions of insulin. So we're going to have a state where the effects of insulin is still being produced. The beta cells in the islets of Langerhans are, I think I said that right, are working just fine. They're producing insulin, but the problem is that the placental hormones are antagonizing their actions. So it's kind of like diabetes type 2. The tissues are not going to be able to activate or work with insulin. In addition to that, cortisol is going to be increased threefold, and when that happens, we are going to have an increase in glycogenolysis, which is the breakdown of glycogen to produce glucose, as well as gluconeogenesis, which is the development of new glucose. And so we're going to have a much higher increase in just simply systemic glucose. Mix that with the antagonism of insulin, and we can have gestational diabetes. This is also specifically problematic with the fact that it can pass freely from mother to infant or child in circulation, which can cause fetal hyperinsulinemia, and that in itself can be very problematic from the perspective that chronic insulin can, or hyperinsulinemia in developing babies towards, I think I had something on here at some point. Did I? Maybe not. I feel like I had something on that. If nothing else, what that can cause is profound hypoglycemia in the infant shortly after birth. And I believe there's also some kinds of birth defects or impacts to metabolism in the infant towards the later end of pregnancy. All right, so the overview of diabetes treatment. We want to prevent long-term complications such as neuropathy, nephropathy, neuritis, that thing with the eyeballs. And to do so, we got to control blood glucose levels and control blood pressure and lipids, since those are also something that's at risk of going out of whack with poor sugar maintenance. With type 1 diabetes, we want to provide a comprehensive plan for the patient, including diet recommendations, how to do blood glucose self-monitoring, balanced exercise ideas, and insulin replacement, because in type 1 diabetes, they have no insulin. It's just, it's not there. So the main stimulus for insulin release is an increase in blood glucose. If we don't have enough insulin in the body, we're going to have, of course, hyperglycemia. We're not going to use as much glucose, and so the body's then going to rely on proteins that are degraded into amino acids and fats that are converted into free fatty acids, which, in the case of type 1 diabetes, means that we're going to have at risk for diabetic ketoacidosis, which is a life-threatening situation. So there are many types of insulin. It can be very overwhelming. I don't necessarily have these down, and it's more of a, you figure out which things your facility uses and you remember those. We have our rapid acting, which is going to be Lispro or Humalog, and this is going to be a clear concentration. We also have our short duration but slower acting, so it's a little bit slower than rapid acting, known as regular insulin or Humulin R. Then our intermediate duration, neutral promatine, Hagedorn, I don't know, NPH. Call it something easy. This is the one that's cloudy, and this one you also must agitate before administration, because that cloudiness means is we have particles in that you shake it up and mix it together and it creates an equal solution. And then we also have our long duration Lantus, which is very common in the hospital as well. Um, Remember that the clear and the cloud, and no, don't go based off of that. The short duration, Lispro and regular, can be mixed with NPH. Lantus, you can never mix anything with Lantus. And we'll get to it here in a little bit, how you mix Lispro, regular, and NPH. There are numerous types of insulin delivery systems, such as inhaled insulin. This is a short duration, so it's going to be similar to our Lispro. Um, there's some potential for lung sequelae, being that we have the ability for like long-term secondary conditions because of the use of inhaled insulin. Sometimes the lungs don't do well with certain medications being shoved into them. And it's not really well tested in those who are under 18. I've actually never seen or provided anyone with inhaled insulin. I don't think that the evidence supports it that much. The other types that I think we get into here in a bit, yeah, this guy right here. This is very effective, very popular. Portable insulin pumps or implantable insulin pumps. Most patients love this stuff because it makes life just a lot easier. So I don't remember any of this stuff. I just remember that with our short-acting insulins, they're going to have a much quicker onset of action, their peak is going to be shorter, and the duration is going to be shorter. And the same goes for our regular. It's going to be a little bit longer. The intermediate acting is going to be a little bit longer than our short, a little bit longer than the peak, a little bit longer than the duration. Our NPH is going to be just a little bit longer than that even, and our long-acting is going to be even more so than that, and there's actually no peak for Lantus. Friggin' trucks outside. So yeah, I mean, memorize this if you want to. I'm not sure if Rachel wants you to for the test, but I don't think most of us have this down. So we can give, when it comes to dosing, we can give a fixed dose. That's okay, especially for those who are newly diagnosed. But we don't want to stick with that because, as with anything else, normally our hormones are changing. They vary based on the stimuli, how much sugar we have, and what else we're going doing with our day. The sliding scale is very, very popular in the hospital setting. It's easier to work with and think about for nurses who have to do it with multiple patients. But it may be on its way out, especially for those with at-home methods. So for the non-ICU patients, what seems to be the best option right now is that we give a basal form of insulin, a nutritional form of insulin, and a correctional form of insulin. So with our basal insulin, this is kind of like our general needs, baseline basal needs based on what we're doing. We have then also so like this would be some like Lantus. Nutritional insulin we have as based on how many carbs we expect to have per day, per meal, that is. So for example, we are going to do a carb to insulin ratio of 10 to 1. As an example, there may be a difference per patient. And so if they're going to have 30 grams of carbs, and that requires then counting carbs per meal, then they'll require 3 units before breakfast to ensure that this meal gets fully absorbed, or that the glucose, as it breaks down, gets fully absorbed into the cells, the tissues. And then we also will have correctional insulin. So this would also be, this might be more like NPH or regular. And then we also have our correctional insulin for pre-meal blood sugars that are too high. And for example, the goal for glucose before a meal is under 150. So if it's, in this case, 200, then you would take, or above that, Then the order would be to take 1 unit of insulin for every 50 milligrams of milligrams per deciliter over 150. In this case, since it's 200, thus only 50, that would be to take 1 additional unit along with your nutritional insulin right before your meal. So they would have to go, the normal idea is that the patient would wake up, they would take their Lantus as just a normal part of their day, which may be adjusted in the long spectrum to adjust for their energy, their intake in general, all that. Then let's say they would go on to breakfast, even right away. They would take an additional insulin dose. They would check their blood sugar. If it's under 150, if that's the goal, then good. They don't need to take any of their correctional. They just need to calculate their carbs and figure out how much they take for nutritional insulin. This is a bit more complicated, and it does take practice and knowledge, but this is a bit more appropriate and a bit better, or more similar to what is normal for our physiologic. My brain's not working today. This is more closely aligned to what the body naturally does on its own. Okay, so when mixing insulin, we are able to mix NPH, which is an intermediate insulin, with our short-acting insulins only. So that's going to be like Lispro and regular insulin. The way that we do it is we do it as cloudy, clear, clear, cloudy. So how that works out is, let's say we have 1 unit, 1 unit of, actually I'll go over here and draw something. Let's say we've got one, holy thick ink. 1 unit of regular and 2 units of NPH. So this is how much we want to give. We want to give it in 1 syringe to a patient because we don't want to poke them and make them bleed and hurt any more than we have to. We want to be their friend, not their skin needle poker. So the way we do this is we go cloudy, clear, clear, cloudy. And remember that NPH is cloudy and regular is clear. I don't know if it says in here somewhere. So this one's clear. So we're going to take our syringe, and before we touch the vials, we're going to suck up 3 units of air in syringe, so that we can inject that into the vials, because most of the time these vials are multi-use vials. So we are pulling up 3 units into the syringe. We are going to inject our 1 unit of air into the regular insulin. We're going to then pull the syringe out. We are not pulling in any insulin yet. No, I'm sorry, NPH. I'm getting something mixed up. We're going to go to NPH first, because this is cloudy. I'm going to say it over here. We're going to inject our 2 units of air into NPH. We're going to pull the needle out. There's no insulin in the syringe yet. We're going to stab it into the regular. We're going to inject our 1 unit. And then we're going to we're going to pull up our 1 unit from our clear vial, and then we're going to go back into our NPH and pull up our 2 units. The idea here is that we do not want to risk contaminating the short-acting insulin with NPH. The short-acting is the most important when it comes to we need to have the exact right dose because it acts fast, and it can be very detrimental if we don't have the exact right dose. We need the regular to be the right dose. So we do not want to risk pulling up stuff on NPH, going into the regular vial, and accidentally getting contents from the NPH vial into the regular vial. And the way to remember this, in regards to whether we go cloudy or clear, is it clear, cloudy, cloudy, clear, or cloudy, clear, clear, cloudy? Think of the insulin as a year. So when it comes to the weather throughout the year, starting in January, it's cloudy. It's winter, especially if we're talking about Oregon. It's cloudy, it's rainy, it may be snowy, it's cloudy. Then we got later part of spring and summer or early part of fall. We got a whole bunch of sun. It's sunny, it's clear outside, it's beautiful. And then towards the end of the year, we are entering October, November, December, and it's cloudy again and rainy and all that stuff. So that's how I remember cloudy, clear, clear, cloudy. All right. So again, with sub-Q injections, we can do that with a syringe and needle or with a pen and jet injectors, though it depends on whether the manufacturer has made that into a pen and jet injector. We can do the subcutaneous infusions via a portable pump or the implantable pump. IV is helpful for emergencies, and then inhaled is also another potential option. We need to make sure that we always refrigerate our insulin, and then once we open it, we are able to allow it to not be refrigerated after opening, but we've got to use it within 1 month. But if that expiration date it comes up, before that 1 month is over, then we gotta stop using it. Don't expose it to direct sunlight or extreme heat. Keep it inside a nice, cool, dark cabinet thing or drawer. For diabetes, insulin giving or giving insulin to diabetes patients. God, my brain is just not on today. We're going to give it to all patients who have type 1 diabetes, and we're going to give it to some who have type 2. We're going to give IV insulin for patients who have DKA. We may also use it for hyperkalemia because let's say we've got ourselves an acidosis on our hands. What does acidosis do to potassium? Potassium normally sits inside the cells, and with acidosis, out comes the I gotta make sure I'm saying that right. Okay, yeah, so with acidosis, potassium is going to end up exiting the cell and going into the extracellular fluid. With alkalosis, we're going to have the insulin, or not insulin, we're going to have the potassium going into the cell. So when we have an acidosis patient, they're going to be hyperkalemic. And again, we know that insulin helps to shuttle potassium back into the cell. We can also use insulin to help diagnose growth hormone deficiencies. So most of the time this happens in kids, and when this happens, we can use insulin by inducing hypoglycemia in these patients. When we have hypoglycemia in our bodies normally from insulin, we will trigger a release of growth hormone. If they have a growth hormone deficiency, then they can measure the growth hormone result from having hypoglycemia from insulin. And if it's not up to what it should be, then we can say, hey, all right, we know that they have a growth hormone deficiency. Some adverse effects of insulin therapy. So, of course, if it works well to reduce glucose, it can work too well at the same time. So we can result then in hypoglycemia if we give too big a dose, leading to brain damage and death, because the brain requires oxygen and glucose as its primary two things. This right here is a example of lipohypertrophy. This place had insulin shots too many times, and it can dramatically change the absorption rates of insulin. So we want to make sure that's why we rotate our injection sites to allow for the skin areas to recover. Very rarely we can get allergic reactions. When they do happen, also, they tend to be pretty um, not pretty calm, not very severe. And then, of course, if we give insulin too much, we can shuttle too much potassium into the cells, because we just covered that. So for hypoglycemia, this is going to be where we have a blood glucose level of 50 or less. Though some protocols will say 70 or less or 60 or less to treat, depends on your policies. So this can come from insulin overdose, a decrease in food intake, vomiting, diarrhea, increased alcohol intake, excess exercise, and trauma. So what we're going to do when we see this is we're going to always hold insulin. We are not going to give insulin when they're already hypoglycemic. That would be bad. Um, we are going to give oral sugars, which are not as good as IV glucose. IV glucose is the golden standard if they are very hypoglycemic, but this can be nice from the perspective that it can work decently fast, and people don't like getting IVs if they don't have to have IVs. And then glucagon is also a potential option, but glucagon takes a bit longer. Speaking of, so we can give, the preferred treatment is IV glucose, but we can give glucagon as well. It'll just not be as fast. IV glucose will immediately increase the blood glucose levels because we're giving it right into the blood, right into the the arteries. No, veins. Um, and glucagon is given sub-Q and IM, which means they require some time to then be absorbed, and it's a hormone that works in the liver, so it takes a little while for it to do its duty as well. But we can use it. It just takes a while longer. So drug interactions, of course, don't give um, insulin therapy will work with hypoglycemic agents in that the insulin is going to reduce the glucose. Hypoglycemic agents are going to reduce the glucose as well, so we may get a very reduced hypoglycemic effect. Hyperglycemic agents may counter insulin because they promote more blood glucose from glycogenolysis and gluconeogenesis. And then beta blockers can be problematic in that they can delay the awareness of that increase of heart rate that normally we all get when we become hypoglycemic, and diabetic patients tend to use that as an identifier that, hey, I need to get some sugar. So our goal is to maintain acceptable blood glucose levels. We want to make sure that we prioritize how we store the insulin, refrigerate it, use it within 30 days after we open it, but once we open it, we don't need to keep it refrigerated, but just make sure we keep it in a dark place. That's nice and cool. Proper preparation. We got to make sure that we have 2 RNs check, because this can result in death if we don't give it correctly, and make sure we have the right injection site. And we also want to teach the patient on how to make sure that they can recognize adverse effects like hypoglycemia, diabetic ketoacidosis, primarily for those who are type 1, and especially kids, since kids may not be as fine-tuned to when their body is feeling different. And then end organ damage, such as neuritis, nephropathy, neuropathy, all that fun stuff. Okay, so diabetic ketoacidosis, this is a medical emergency. Death can easily happen here. What's going on is there is altered glucose metabolism going on, which is typical for someone who's diabetic. But there's, as with type 1 diabetes, there's no insulin in the body. And maybe they stop taking insulin externally as well. Now they're becoming hyperglycemic, because they're not using their insulin, or the insulin's not there to shuttle glucose into tissues. So first, the body's going to try to get rid of a lot of this extra sugar by peeing it all out, polyuria, and then that polyuria is going to make people thirsty, so polydipsia. Um, and then the fact that we don't have sugar in our body feeding our cells, that's going to trigger our hunger sensation and make us, or increase polyphagia, need to eat. Um, with the lack of sugar, the body requires something to live off of, and our body can resort to fats and lipids, especially those that are stored in our body. So we're going to have, um, well, backtrack here for a second. With that loss, that polyuria, we're going to end up having water loss and thus potentially severe dehydration. And with severe dehydration or any dehydration, we're going to have more hemoconcentration. So we're going to have the viscosity of our blood is going to increase and become super thick. That's not going to work well for being able to um, have blood go and provide oxygen to distal tissues. Our core should be okay, but that's one of the reasons why people with diabetes that don't treat it or maintain it well, in that they have high levels of sugar on a regular basis. That's one of the reasons that we have neuropathy, nephropathy, and neuritis, is because those small, tiny blood vessels are not able to get the oxygen they need to survive, um, as well as the sugar. Um, so back to this. So the body doesn't have any glucose to work off of, so it's going to resort to whatever it can. In this case, fat metabolism. As it does so, it creates keto acids as um, a byproduct, or like it's something that they can live off of. So the treatment for this, and what that does also, is that makes the body acidotic. So not only do we have someone who's got dehydration, profound dehydration, um, severe weakness, they're going to suddenly now become acidotic on top of that, and this can become absolutely life-threatening. So treatment, insulin replacement, get that sugar into the body, and stop the lipolysis. Bicarbonate for the acidosis from the keto acid production. Water replacement along with sodium and potassium replacement, since we're going to be losing a lot of electrolytes through the urine, as well as the water. And in the end, normalize glucose levels. With type 2 diabetes, so we bounce from type 1 to type 2, requires a comprehensive plan. We want to screen them and treat them for hypertension and neuropathy, nephropathy, retinopathy, and dyslipidemia. These are commonly occurring with diabetes that's not well maintained because of the fact that we have the hemoconcentration. Um, and we want to make sure that we are providing glycemic control with a modified diet, with exercise, um, drug therapy, which may be insulin, depending on how much they're producing, or it may be other hypoglycemic, oral hypoglycemic medications. And then we also want to monitor the blood glucose um, over time using HbA1c, which can check for roughly 90 days of history, the length of a red blood cell's lifetime, um, and educate them on how to monitor and treat themselves with their medications. All right, fun stuff now. The oral hypoglycemics. So we have 5 categories according to this. I think we actually have 1 or 2 more that the book mentions. We have biguanides, which are going to reduce the hepatic glucose production. So that's going to be in that we are reducing glycogenolysis and gluconeogenesis. We have our sulfonylureas, which are to increase the insulin secretion or the effects of insulin. So making insulin either more productive or making them work better. Our sodium glucose transporter 2 inhibitors, which will increase the renal excretion of glucose. So in that, we are sodium glucose transporter 2 are, I believe, are the enzymes? I have it down somewhere, but I'll get to it in a bit. They are a thing, because I don't know off the top of my head, that helps to reabsorb glucose into the body from the renal tubules. Our alpha glucosidase inhibitors will decrease the absorption of glucose in the small intestine, and then we have our thiazolidinediones, which are insulin sensitizers to reduce insulin sensitivity or resistance. We want to increase insulin sensitivity, decrease insulin resistance. Okay, there's going to be a lot of red. Biguanides. So metformin or glucophage is going to be our main biggie for biguanides. This is the drug of choice for initial therapy of type 2 diabetes. Mechanism of action here is that it's reducing the hepatic glucose production. So we are reducing how much glycogenolysis and gluconeogenesis is occurring in the liver, and we are improving glucose tolerance in the fat tissue, adipose tissue, and skeletal muscle tissues. This does not stimulate insulin release. So the benefit here is that there's little, if any, cause or risk of causing hypoglycemia. We are simply reducing how much the liver is producing, and we are improving how tolerant the body is towards glucose and insulin. This medication, unfortunately, is not metabolized, which means that the kidneys are going to excrete it unchanged. And so if we have any kind of renal impairment, then metformin can accumulate to toxic levels. And as we can see here, toxic levels can result in metabolic acidosis, which is not fun. So the uses for biguanides, metformin, is pre-diabetes and type 2 diabetes and gestational diabetes. Unfortunately, we have some side effects such as appetite, a decrease in appetite, some nausea, some diarrhea. We also have a decrease in B12 and folate, which can contribute to peripheral neuropathy as well. It can kind of promote it, but only if the body's already kind of on its way towards that. If we take too much metformin, and this is a big education point for patients, that can lead to lactic acidosis, which has a very high mortality rate. And the reason for this is that we have inhibition of mitochondrial oxidation of lactic acid, which leads then to accumulation of lactic acid and subsequent lactic acidosis. So the key here is that we want to keep this at the recommended doses, and we also want to avoid this medication in patients who have renal dysfunction. So we all kind of know what metabolic acidosis is at this point. So metformin, our indications here is that we're going to continue with our lifestyle modifications, diet, exercise, all that. We want to identify high-risk patients, which are going to be those who have renal disease or those who have alcoholism, since the patients who are taking metformin are already at risk of having lactic acid accumulation. Alcohol itself also will impair the breakdown of lactic acid, so they're going to work together to form an even greater risk of lactic acidosis. Being as such, we want to advise against any alcohol use. We want to teach signs and symptoms of lactic acidosis because simply taking this, patients are at risk of developing lactic acidosis, and being able to observe the signs and symptoms means they can get medical attention as early as possible, making their chances of living better. There's also potential for some GI upset, but that will decrease over time, and will be better if they take it with food. So sulfonylureas would be glyburide or diabeta. This was the first oral anti-diabetic medication, and it was created back in the 1950s. So these have been around for a very long time. These are going to increase insulin secretion from the beta cells. So they require some form of insulin production in the first place. If they don't have any, then this medication is useless. This medication will not do anything in type 1 diabetic patients. With the increase in insulin, we therefore do have the opportunity for hypoglycemia. Because if you have too much insulin secretion, if the dose is not tailored just right to the patient, or they have a change in their diet or activity, then the scales go out of whack and the balance goes off. They also have the potential for GI upset and potentially cardiac toxicity. I am Ron Burgundy. And the hypoglycemia is also dose dependent and is more likely in those with hepatic or renal dysfunction. This is contraindicated in pregnancy and breastfeeding, since it can be teratogenic during pregnancy and can cause severe neonatal hypoglycemia at birth, similar to a patient or a infant having, I think it was or having high levels of glucose in the blood to begin with, can cause the infant to also have hypoglycemia at birth because the infant becomes there are a couple different mechanisms. With the high blood sugar, the baby becomes used to it, producing high levels of insulin in response to it, but then they're not getting the same level of sugar after they're born. Whereas with this is going to result in kind of the same thing, but it's going to be because the baby has a higher increased or higher level of insulin secretion from their own beta cells, and they're going to then have less sugar on their own when they leave the womb. The possible interactions are going to be alcohol, other hypoglycemics, since we're going to have a profound effect of insulin and other hypoglycemics lowering the blood sugar even more, and beta blockers for the same reason as previously. This part is a little extra, not something you need to know about, but I found kind of interesting from the book. Alcohol can cause what's called a disulfiram-like reaction and potentiate hypoglycemia. So disulfiram is used to treat alcohol use disorders by making it unpleasant to ingest alcohol. When patients who are taking disulfiram mix alcohol with their disulfiram dose, this creates acetaldehyde syndrome, which in its mild form will have nausea, copious vomiting, flushing, palpitations, headache, chest pain, hypotension. In the severe manifestations, we're going to have life-threatening symptoms, including respiratory depression, cardiovascular collapse, dysrhythmias, myocardial infarction, acute CHF, convulsions, and death. So when we take sulfonylureas and mix them with alcohol, we have the potential of producing a reaction that is on a spectrum from a mild form with these symptoms to a severe form with these symptoms. So we want to educate our patients to avoid alcohol if possible. So we're going to continue with our lifestyle modifications. We're going to continue to advise against alcohol use, identify high-risk patients, such as those who are pregnant, breastfeeding, have liver disease, or are maybe alcoholics. We want to teach about the signs and symptoms of hypoglycemia, as is universal for most of these people, and to take food with the medication to minimize the GI upset. All right, so SGLT2 inhibitors. So SGLT2 are responsible for transporting glucose molecules out of the renal tubules and back into the epithelial tissues, epithelial cells. So without SGLT2, we would have more urine or more glucose going into the urine. When SGLT2 works, it takes glucose out of what would be the urine and preserves it in the body to be used by tissues. Normally that's good, but for diabetics that's not good. So inhibiting it is a great way to reduce how much sugar is in our body. And so that ends up increasing the renal excretion of glucose. The side effects is, of course, the increased urination, the acute renal failure that can occur from the fact that these are playing wonky on the kidneys, um, and serious UTIs, hypotension, and female genital fungal infections, because with the increase in glucose in the urine, the state of the urine itself, with the added benefit of glucose, makes that medium a great medium for bacterial growth or microbial growth, because it can be both fungal or bacterial. So again, we don't want to give it with any hypoglycemics. And antihypertensives may produce a profound hypotensive effect because we have a lot of loss of fluid with this through urination, mixing that with antihypertensives, and suddenly we've got a profound hypotensive state, potentially. So lifestyle, drug, identify renal failure is the big guy here. Expect an increase in urination. Expect some orthostatic hypotension, risk for infections. Monitor our kidney function. Alpha-glucosidase inhibitors, or acarbose. Oh, this is also pronounced canagliflozin. So acarbose, alpha-glucosidase inhibitor. Alpha-glucosidase is an enzyme that lives on the brush border of the intestines, the small intestines. And its job is to break carbs down into monosaccharides, and by doing so, makes them more bioavailable to the rest of the body and for absorption. And we are decreasing we are decreasing the ability of those carbohydrates to be absorbed in the intestines, and that reduces how much the blood sugar or blood glucose levels in the blood will rise after a meal. So we can use this along with insulin, along with also metformin or sulfonylureas, and we're using it only also in type 2 diabetes, and it acts locally in the gut and has very negligible systemic absorption. So it's pretty pretty good about not causing any other symptoms. But there's the potential of GI upset, gas, cramps, and diarrhea, because there's going to be a secondary issue of bacterial fermentation with that extra sugar in the gut, and all that extra stuff's going to cause that. They can also have a decrease in iron absorption with acarbose, and liver dysfunction due to, or if we have long-term high doses of acarbose. But the liver dysfunction is reversible with discontinuation of the medication. Lifestyle, exercise, look out for liver disease. If they're taking metformin, that may lead then to an increase in GI upset. Take at the beginning of a meal to reduce the GI upset, and we want to do liver function tests on a decently regular basis, so that we are ensuring that they are not having the liver dysfunction. All right, our thiazolidinedione, or pioglitazone. This works to decrease insulin resistance and decrease glucose synthesis, and the insulin resistance comes from activating insulin-responsive genes that help to regulate carbohydrate metabolism. So they're actually working in the nucleus on the level of the genes of cells, to promote better insulin sensitivity. Unfortunately, there is a risk of renal fluid retention. And what happens with that is that can then worsen heart failure. Trying to remember why it was that I guess it doesn't say. It must not have said in the book. There's also the risk, of course, of hypoglycemia. There's some potential for hepatotoxicity and lipid changes from taking pioglitazone. All right, so the book doesn't really go into detail on how pioglitazone creates renal fluid retention, but just go with it. And know that it will worsen heart failure. It's a thing that we need to be cautious about in mild hyper or mild heart failure, but super cautious about in, if not like contraindicated with severe heart failure. Hepatotoxicity comes from um, the fact that we have P450 or cytochrome P450 inhibitors or inducers that can impact metabolism, I think. Um, and so, speaking of that, atorvastatin will be a P450 inhibitor, which means that we will then have an increase in pioglitazone levels if we mix atorvastatin and pioglitazone. Rifampin and cimetidine are P450 inducers, which means we're going to have a decreased level of pioglitazone when taken together. And then the worsening of heart failure from renal fluid retention is even more profound if we have a mixture of insulin and pioglitazone. So, for those who have heart failure or severe symptoms of edema, we don't want to mix pioglitazone and insulin together. So, lifestyle modifications. Identify heart failure patients as high-risk patients. Teach about the signs and symptoms of hypoglycemia and heart failure, since heart failure is an issue here. We want to strongly advise against the use of insulin and against the use of any P450 inducers or inhibitors. And then we want to also check for liver function tests on a regular basis. All right. So HHNS, I think I've also heard it HHNK or NKHH. There's a lot of different options. So this is the equivalent of DKA, except this one's in type 2 diabetics. And the reason why it's worse, it's not worse, it's different. And I think it's not worse. HHNS is what occurs when there's still a little bit of insulin working in the body. So in this case, we don't have enough to meet the demands of the body, but we have just enough insulin to make it so that we don't have to resort to the breakdown of lipids into ketones. But we still have a very large glucose level developing and building in the blood, leading to extreme urine loss. And with that comes severe dehydration. Now, this kind of tends to, I'm going to bounce over here for a second. This tends to occur over 1 to 2 months. A lot of times patients may not necessarily notice it, or they may just feel weird, and all of a sudden their blood sugar levels are above 600. And with that dehydration will then come a decrease in blood volume, which, if it becomes severe, will eventually lead to seizure, coma, death. This is a type 2 diabetic issue, and it's a slow, gradual progression. I think this right here, the advanced age, which I saw nowhere in the book, severe infection, illness, or other stress was mentioned with here. I'll try highlighting that, see if that works. That won't be helpful. So this part here, DKA occurs mainly in patients with type 1 diabetes, whereas HHS occurs in type 2, and DKA is usually associated with infection, acute illness, or some other stress. Infection, illness, or other stress. I think there was some mix-up there potentially, because HHS occurs and evolves slowly. So, I don't know. I think that was maybe a goof up. Anyway, so let's see here. Management of HHS, we're going to want to correct the hyperglycemia, give enough insulin, and we're also going to want to replace fluids and electrolytes to treat the dehydration.